Nursing Care During Labor and Birth, Chapter 10. The Role of the LPN during labor and delivery. So, as we talked about, you will not actually be responsible for laboring the patient. However, you are going to be in a part of the care. You're going to be recognizing, managing any kind of complications that might arise in the process. You're going to give intense support to that laboring woman and her partner or coach. You're going to facilitate the labor process and ensure safe passage of the laboring woman and the fetus through the event. Okay, so immediate assessment. When that woman comes up to the floor, there are some things that we are just immediately going to ask her. Birth imminence. Is it happening? What is going on? Are you having contractions? Where are you in this labor process? That's what we're trying to figure out. And so there's a lot of questions we'll ask her initially. And this often takes place right there at the nurse's desk. She'll come up, she'll say, I think I'm in labor. We'll ask, when is your estimated due date or your EDD? Are you having any contractions? How frequent? How long are they lasting? When did they start? What about rupture of membranes? She might not be sure, or if she did have a rupture of membranes, you're going to ask about the color, the consistency, how much, did it have an odor? And what we're looking for here is to make sure that when her water broke, that there wasn't any amniotic fluid in it. Not amniotic fluid, it's all amniotic fluid, that there wasn't any meconium in it. And that is that first stool of the baby. Sometimes they'll go ahead and they'll pass that stool while they're still in the mother. And when the water breaks, you'll see a green or a yellow tinged water as well. And so we're worried about infection if that occurs. So we're going to be asking her, what did the fluid look like? And sometimes she might not have noticed anything. She'd say just water, and that's a good sign. We're going to be checking the fetal and maternal status. We want to know how that baby's doing. Is it moving? Are you feeling the baby move? And then risk factors. Did the mom have any prenatal care? Is she coming straight in without any prenatal care? Is she a smoker? Does she drink? Remember, all of those things put that baby at risk. So we're asking about that. Any kind of cocaine use, illicit drugs, all of those things we have to know. Any risk factors as far as chronic disease? Are you diabetic? Do you have hypertension? Have you had any problems during the laboring or during the whole pregnancy? Okay, moving on. Additional assessments if birth is not imminent. We're going to be checking the maternal history, health history, physical history, status of labor, where she's at. She might not be, the baby is not right there in the birth canal, but still she's having contractions and she's entering into labor. The labor and the birth preferences. Does she have a birth plan? And for an example of a birth plan, you can go to page 157 and look at that. Along with maternal health history, remember that gestational TPAL we talked about, GTPAL, gestational term, preterm, abortion, and living. We'll be asking her that, and we need to know that. Going back to the rupture of her membranes, if she doesn't know exactly, we can use nitrate paper, and that will show up. It'll change colors depending on whether it's just fluid or if it's actually amniotic fluid. So that's another way that we can figure out where she is in the whole labor process. We'll also be wanting to know the fetal status and where that baby's laying. And one way that we check that is through Leopold's maneuvers. And if you'll look on page 207, you'll see a box which explains all of that. So look through Leopold's maneuvers and kind of get an understanding of exactly what that is. It's just checking to see where that baby is located, what the lie of the baby is. Components of the admission history, again, it's going to be obstetric history, current status, medical surgery history, social history, desires and plans for the labor and birth, and then desires and plans for the newborn, going back to the birth plan on both of those. Admission lab, so this is at the point where we have already taken the woman back to triage. We have hooked her up to the electric fetal monitoring. We're watching the baby. We've got her vital signs. We're checking her out. And now we are going to go ahead and do a vaginal check on her and see how far she's dilated, if she's effaced. Now, if she is at a 4, then that is an automatic admission in, as long as her labor is progressing, that she's still having contractions, good contractions, consistent contractions. And if she's at a 4, we'll go ahead and say that she is indeed in active labor, and we'll admit her into the hospital. So along with the admission comes labs. And with these labs, we're going to do a complete blood count, a CBC. We're going to do a blood type and RH factors, so you'll see them do the blood band, the blood type in honor. You'll see the serological studies, the VDRL or the RPR, and that's checking to see, checking for syphilis, any current infections that might be active at the moment. Rubella titer. If it's not done prenatally, we'll go ahead and check her rubella. But if the woman is immune or shows immunity, then we won't have to worry about that. The ELISA is to detect for HIV antibodies. And again, remember, we checked it at the beginning, we'll check it at the end. This does, however, involve informed consent. We'll do a vaginal and cervical cultures, and that's checking to make sure that she doesn't have any STIs that are current, gonorrhea, chlamydia, or the group B strep. And then we'll also do a urine analysis on her, a clean catch specimen. And in that, we're of course checking to make sure that she isn't leaking protein, ketones, anything like that. Okay, so now she is in bed, we've got her hooked up to the monitor, and we are going to start monitoring her contractions and the fetal heart rate. So we'll put her on an external method of monitoring these contractions. And what it's called a TOCO, or a TOCO dynamometer. Just call it a TOCO, it will be much easier for us all. But this is going to measure the contraction, the frequencies, and the durations. Now, it does not show us quite how strong it is, and the way we feel out how strong it is just by feeling. A mild contraction on the fundus, which again is that top part of the belly. The fundus is going to feel like the tip of your nose on the peak of a contraction, so it's still kind of soft and squishy. The moderate contraction is going to feel like touching your chin. You can feel that bone, it's a little bit harder, so that's a pretty moderate contraction. And then a strong contraction, if you don't have a lot of flimsy skin like my forehead, it's right there, pushing on your forehead, it's strong. And so her whole belly will feel really tight if she's having a strong contraction. The internal methods, this is an intrauterine pressure catheter. And now for this to occur, her membranes have to be ruptured. And so the only way that you're going to do an internal catheter on her is if her membranes have been ruptured. And it could have happened spontaneously, or the doctor could have gone in and ruptured her membranes for her. Okay, so with an internal pressure catheter, the catheter tip is placed on the presenting part of the baby. Usually it's going to be their head, and it'll be in their scalp, and it's connected to the fetal monitoring. It records the frequency, duration, and this time it can actually get the intensity of the contractions. So that will be inside the mother. Intermittent auscultation of fetal heart rate. We don't really practice this at BSA or Northwest. It's an acceptable method for low-risk pregnancy, but oftentimes if a woman's coming in, we're going to put her on the fetal monitoring system, and we're going to keep her on that. However, for these women and for some birthing centers, they'll do that intermittent. They'll let her get off the machine. They'll go as long as the baby's doing fine, it's having a reassuring pattern. Then they'll let her kind of wander and walk around and just check her intermittently. Okay, so monitoring the fetal heart rate. It's a continuous electrofetal monitoring. This is what we're going to see at BSA and Northwest, and what you'll be working with and seeing while the patient is in labor. It's going to be an external electrofetal monitor, and it's an indirect way. It's not inside, it's not invasive. It's the most common way to assess the fetal status during labor. It works on the principle of ultrasound, and then characteristics of the fetal heart rate pattern can be monitored continuously via video display and through a continuous printout. So when you're in the hospital and this monitoring system is hooked up to the mom, you'll see that she has 2 straps on her, and there's kind of like these electrodes on her belly. And what that is doing, it's measuring the contractions, which is one, and then the fetal heart rate, which is the other one. And right beside her is a machine that has red paper coming out of it, or red lines on the white paper, and it's showing the contractions as well as the fetal heart tones. Okay, so external, indirect, TOCO monitors the contraction pattern, and it helps to screen for signs of fetal compromise. It's sometimes difficult to get that consistent tracing if the fetus is too small or if it's extremely active. And so one way, if we cannot get a good reading on that baby and we're concerned, we might go ahead and do an internal electrofetal monitoring, and this is going to be an invasive procedure. It's the spiral electrode. It will be attached to the presenting part, often their head, and it actually goes underneath the scalp. And you can see a picture of that in your book on 213. And so of course, the membranes have to be ruptured, and that spiral will go inside the baby's head just a little bit. So of course, with this, it increases the risk of maternal and fetal infection and injury. It is invasive, but it is easier to obtain a consistent tracing, and it records the graphic representation of the fetal heart rate. Okay, so when we're talking about evaluating fetal heart tones, you have your baseline fetal heart rate. And with that, it's measured between uterine contractions during a 10-minute period. The normal acceptable baseline for a fetus is going to be 110 beats to 160 beats per minute. And when the baby comes out, that is the normal heart range that we're looking for as well. You'll be listening in the nursery to their heart rate and trying to count them, and it's going so fast, 160 beats per minute. A lot of times you'll have to start over and recount them because it's just going that fast. But again, what we're looking at whenever we're looking at these fetal heart rate patterns, we want baseline variability. And that's saying that we want fluctuations in the fetal heart rate. We want to see it go up from baseline. That's showing us that this fetus is able to compensate, to recover from being distressed. It's evaluated visually on the unit. Normal if the fluctuations are greater than 6 beats per minute and less than 25 beats per minute. And again, remember, we're wanting that 15 by 15 window. And 15 beats up, 15 seconds. A reassuring sign that the fetal nervous system is intact. And so as long as that baby is having variability, it's showing us that that baby is responding, that it's recovering, it's compensating, and that is a good sign. 3 major deviations from a normal fetal heart rate baseline. You can have tachycardia, and that's going to be that the baseline rate is greater than 160 beats per minute. You can have bradycardia, which means the baseline of the fetal heart rate is below 110, and then you can have absent or minimum variability, and this is a non-reassuring pattern. Again, we want to see that that baseline is going up and down. That's reassuring to us. Okay, for these to be counted as a deviation and for them to be a bad sign, they have to continue for at least 2 minutes. If they were to continue for 2 minutes, that's when we would go ahead and do further testing to make sure that that fetus is not in distress. Okay, so periodic and episodal changes. Periodic changes are variation in the fetal heart rate patterns that occur in conjunction with those uterine contractions. Remember, we talked about the placenta being squeezed, and when it's squeezed, that blood supply is cut off to the baby. That's causing stress to the baby. The baby's heart rate is going to go up. That is normal. So as those contractions are happening, remember there's on the strips, the contractions are on the bottom. As those contractions are happening, you should also be seeing the baby's heart rate kind of going up along with it. Episodal changes are variations in the fetal heart rate pattern that are not associated with uterine contractions, and maybe that's compression of the cord. If the baby's head is hitting that cord, you'll see variable variations. Okay, so reassuring periodic changes. These are called accelerations and above the baseline by at least 15 beats per minute for at least 15 seconds. We want that 15 by 15 window. Benign periodic changes, these are called early decels. Not a bad sign, not a good sign. It's showing variables, so we're good with it, not a problem. Non-reassuring periodic changes, these are the variable decels indicating some type of acute umbilical cord compression. Like I said, if the head is squeezing that umbilical cord, you're going to see variable decels, and oftentimes they will be a V or a W or just squigglies, but they go away rather quickly. Once that baby changes, moves positions, it'll go back to normal, so we're not too worried about these. Late decels, however, are an ominous sign, and it indicates uterine placenta insufficiency. That baby is not getting what it needs, and we're going to get worried about it. So we're going to do further testing, and if it continues to have late decels, we're thinking the baby is in trouble, and that might mean we need to do an emergency C-section, get that baby out of there. Okay, so measures used to clarify non-reassuring fetal heart patterns. You can do fetal stimulation, fetal scalp sampling, and fetal scalp pulse oximetry. So it's stimulating that baby, trying to figure out why it's having a non-reassuring fetal heart rate. And sometimes that stimulation will jolt that baby out of it, and we won't have to go back into any of those late decels or see anything more on that, which is a good thing. The nursing process during the first stage of labor, dilation. Okay, now remember, with the first stage of labor, it's the dilation period. It's from 0 all the way up to 10, but there are 3 phases in the first stage of labor, and you cannot forget those phases. They're very important. Okay, so with this patient, what we're going to do is focus on assessment. Where is she at? How is her labor going? What stage, what phase is she in this first stage of labor? Fetal heart tones, vital signs, labs, we're looking at all of those. We're going to provide physical care to the mother and the fetus, giving her whatever she needs. If she's able to have ice chips, that's fine. Some doctors don't want any they want her NPO, which there's a debate on whether that's good or not. Of course, if you have to have an emergency C-section, you don't want them to have anything in their system. Providing psychological care to the mother. How is she doing with this labor? Is she handling it well, or is she scared and fearful? Again, anytime they're scared, fearful, have any kind of stress going on, that can impede and slow down labor. So we want to really talk through her and give her that emotional support that she needs. And then keeping the practitioner informed about the labor process. The doctor is not going to be in the room with the patient the entire time, so we have to keep that doctor up to date on where she's at. How far along? Is she a 5 centimeter? Is she 50% in phase, 80% in phase? Is this her first baby? Is she moving her along quickly, or has she slowed down? And then the labor process, again, after 2 hours with no cervical change or dilation, they call it arrestive dilation, and that she's not progressing. And if that were to occur, then the doctor might come in and say, well, let's go ahead and rupture her membranes and see if that doesn't speed it up, or maybe go ahead and start a little bit of Pitocin on her and see if we can't get some contractions going again. Anytime that you're calling a doctor, you always want to remember SBAR, and I know you've heard that before. It's situational, background, assessment and recommendations. So always keep that in the back of your mind. Whenever you're calling a doctor, you want to go through the SBAR. You want to tell them the situation. You want to give them some background information. You want to tell them your assessment, everything that you've seen, and then also your recommendations, what you think this patient needs. Nursing interventions during the latent phase. Okay, so remember, if you need to, go back to page 178 and look at that chart and remember what the latent phase is. And this is where she is 0 to 4 centimeters. So at this point, we're just now getting up to the hospital more than likely. She's having contractions every 5 to 10 minutes, and they're lasting about 30 to 45 seconds. Mild and mild to moderate, not too strong at this point. Okay, so we're going to be implementation. What is our implementation? We're going to be preventing fetal and maternal injury. We're going to be relieving any kind of anxiety. At this point, she's probably still excited in that excited phase. We're going to be promoting comfort, and then we're going to provide patient teaching. Are you feeling the baby kicking? Okay, this is the next step. You're in the latent phase right now. You're 0 to 4, and what that consists of. Your contractions are going to start getting closer together, and they're probably going to start occurring stronger. Letting her know what kind of medications are available to her if she's in too much pain, and what kind of labs you're doing. What are you drawing? What are you sending off? Keep her informed in the whole process of what you are doing. Goals, of course, our goal is that the woman and the fetus remain free from injury. We hope that the woman's anxiety is reduced by keeping her informed. The woman's pain is manageable. Again, telling her what she can have, giving her options. And then the woman and her partner have adequate knowledge of the labor process, that they understand where they're at and what's going to take place and are a part of that. Nursing interventions during the active phase. Okay, with the active phase, now we're 4 to 8 centimeters along. Our contractions are coming on more frequently. It's every 3 to 5 minutes, and they're lasting a little bit longer, probably 40 to 60 seconds. With this one, we're going to be assessing the woman's psychosocial state. Okay, so it's starting to get a little bit harder, and she's probably turning more inward, kind of getting quieter, becoming more introverted. We're going to assess the labor process. Where is she at? How many centimeters? Do we need to start calling the doctor? Is she a gravida 1, gravida 2? Is this her second, third child? You know, those moms who have 4 children and gravida 4 their labor is going to go along a lot quicker than someone who is a brand new mama. So we need to keep the doctor informed about that as well. We're going to be assessing the fetus status. They're constantly going to be on that electrofetal monitoring. And we're going to be watching the wave patterns, making sure that they're not having any decels, making sure they're having good variable. And we're going to be assessing the maternal status. How is mom doing? How are her vital signs? Is her blood pressure okay? Is she breathing okay? Can we work through those breathing techniques? Okay, so for a nursing diagnosis, think about risk for trauma to the woman and the fetus related to intrapartum complications and a full bladder. A lot of times, if these pregnancies or if this labor will go really quickly, it can cause the woman to rip more easily, tear, and so we want to prevent any kind of trauma to that mom. If it does look like she is progressing, you'll see that the nurses will come in and they'll start rubbing that perineum, and they're trying to stretch it out, and so you'll just see them right there rubbing, encouraging her to push. Not yet, but only whenever she gets to the second stage. But before that, they'll be rubbing that perineum, trying to stretch it out so that she does not tear. Acute pain related to the process of labor. What are we doing for pain? How are we helping mom through the pain? Is she wanting to take an epidural? Does she want pain medications, or does she want to do it natural? If she's doing it natural, are we helping her with breathing techniques? Anxiety related to fear of losing control. We don't always feel in control in this whole labor process. So maybe letting her know, okay, here comes another contraction. It's coming. It looks like it's going to be a big one. Let's breathe through it. Keep doing it. You're doing a great job. Okay, just keep on breathing. Good job, good job. And working through those contractions with her. Ineffective coping related to situational crisis of labor. If the woman is not progressing and they're looking at an emergency C-section because the baby is having D-cells, how are we working through that crisis? How are we working with the mom and making sure that she is informed the whole time and knows what's going on? And then ineffective breathing pattern, hyperventilation related to anxiety, inappropriate application of breathing techniques, risk for infection related to invasive procedures, vaginal exams. Anytime you go in, you are putting her at risk. So making sure that we are washing our hands and we're taking every precaution to keep her safe from infection. And then, of course, rupture of amniotic membranes. How long have her membranes been ruptured? And are we watching that? With the fetus, we are going to be checking the fetal heart rate. For a low risk baby, we can do it every 15 minutes. And then for a high risk, it's going to be every 5 minutes. And again, they are going to be on the fetal monitoring. But if it's a high risk baby, the nurse is never going to leave that mother's side. She'll be there the whole time. Okay, identification and planning. Of course, our primary goal remains maintaining maternal and fetal safety. We're always concerned about safety. NCLEX wants to know that you are always concerned about your patient's safety. So keep that in the back of the mind. How do we keep mom safe? How do we keep baby safe? Implementation, we're going to prevent trauma during labor. Again, rubbing the perineum, stretching it out before that baby gets here. Providing pain management, reducing anxiety, promoting effective coping strategies, promoting effective breathing patterns, maintaining oral mucosis integrity, whether it's giving her swabs, giving her ice chips, letting her clean out her mouth however she can, and then preventing infection. Of course, going back to mouth care, just remember as you're breathing out your mouth, it causes that mouth to get dry. So just allowing her to have swabs, ice chips if the doctor allows it, but even just swabbing out the mouth will help her in that. Okay, so nursing interventions during the transition labor. Okay, so transition labor, we are there. We are so close now. We are 8 to 10 centimeters. We're having contractions like crazy now. Every 2 to 3 minutes. They are strong. They're lasting 60 to 90 seconds. And this is the most difficult phase of labor. So what are we going to do? We're going to be assessing the woman for how far along she is. Is she an 8? Is she a 10? Do we need to be calling the doctor? Do we need to be telling him to get on up here, get here? We're going to be assessing the woman's ability to cope. Is she doing okay? At this point, she can't have an epidural, but there still are measures that we can help her with to cope with that pain. Assess maternal status, assessing fetal status, looking at the fetal heart rate, making sure that the baby is doing okay with these contractions. Again, whenever you're thinking about contractions, there has to be a rest period in there. And that rest period is when the placenta gets perfused again, when that baby gets oxygen and blood. If the baby is not getting that, it's going to cause that stress to baby. So we're watching very carefully for that. Of course, at this stage, she cannot push. We will not let her push. Pushing too early can cause edema, and it can cause her to tear, to rip. It'll slow labor because of that edema, and the cervix could get lacerations leading to hemorrhage. So do not let her push until she is a complete 10. And at that point, when she is a complete 10, you're hoping that the doctor's there, because if she starts pushing, you might end up catching. Okay, so nursing diagnosis, we're going to go back to pain. Pain related to frequent and intense uterine contractions, pressure of the descending fetal head. This is where they start feeling a lot of pressure. It might be that she wants to push. She feels like she's just got all this pressure, or that she needs to go to the bathroom. That is saying that that baby is almost right there. And so this is exciting. An ineffective breathing pattern, Hyperventilation, we have to make sure that she is breathing okay and that that baby is still getting oxygen. At this point, if her pulse ox is low, we might go ahead and put some oxygen on her. We might just put oxygen on her for comfort measures. Powerlessness related to intensity of the labor process, and then of course fatigue, depending on how long this labor has gone on. But at this point, the mother may be very tired, and yet this is the point where it's going to be the hardest for her, and she's got to push through. She's got to find that reserved energy somewhere and move on with this intense labor. Planning and identification are major goals that the woman's pain will be manageable. We might not be able to take it away completely, but we want it to be manageable, and that she'll exhibit effective breathing patterns, that she'll work through it. She'll breathe through the labor. She'll maintain a sense of control. She'll be able to rest between uterine contractions. And then implementation, we're going to manage pain the best that we can. Like I said, at this point, it's too late for analgesia. It's too late for an epidural, but there's still local blocks, things that we can give her or that the doctor can administer to help manage that pain. Breathing patterns, a sense of control, supporting the woman through fatigue, and then of course preparing the room for delivery. That baby is coming and will be here very quickly. Okay, this is the second stage of labor, and this is when she finally gets to push. She is at a 10 now. We expect to see that baby soon, and this is so exciting. Okay, so we're going to be monitoring the blood pressure, the pulse, the respirations every 15 to 30 minutes. We are going to be in that room with her. That baby is coming. We're probably not going to leave her by herself. Now what happens if the baby is coming and you're in there and she's saying, the baby's coming, and you're the only one in there as a student nurse? What are you going to do? First off, you're not going to leave her. You're not going to run out the hall, help, someone, the baby's coming. You're going to stay there with her. You're going to be pushing that light, that nurse call real quickly, and you're going to be saying, I am Carrie, I'm a student nurse, and this baby is coming. We need someone in here stat. Get in here fast. But for you, you will not leave that woman. Now, if that baby is coming, are you going to be pushing that head back up into the cervix? No, wait, I'm not the doctor. Get back in. No, you're just simply going to guide. You're going to guide that head out. And wouldn't that be the coolest thing if you, as a student nurse, got to deliver a baby? They're slippery, so make sure you don't drop them, okay? But no, that won't happen. I'm not trying to scare you. I'm just playing with you, okay? But going back to assessment, we are going to be assessing the contractions. We're going to be watching that pattern, and we're going to be looking at it every 15 minutes. We're going to be assessing the woman's report of uncontrollable urge to push. If she has this uncontrollable urge to push, that probably means that that baby is right there, and you'll start seeing the baby's head crowning. We're going to be checking the fetal heart rate every 15 minutes for low risk women, and every 5 minutes for those women who are at risk for complications. Okay, nursing diagnosis. At this point, fatigue is huge, related to the length of the labor and the pushing effort. Risk for trauma related to pushing techniques and positioning for delivery. Outcome identification and planning. The goals for the second stage of labor, that woman will be able to push effectively despite fatigue, and she'll give birth with minimal or no trauma to the fetus or to herself. Implementation, promoting effective pushing despite fatigue, reducing the risk of trauma using effective pushing techniques and positions, and preparing the delivery for that newborn. Okay, the third stage of labor. The baby came out, and now we're waiting on the delivery of the placenta. And this can take place usually anywhere from 5 to 20 minutes. We're waiting for that placenta to come out after the fetus. You'll see that placenta separation, and what you're going to see is that gush of blood, the lengthening of the cord, and then like a globular shape to the fundus. You'll kind of see that. And at that point, the placenta should come on out. You'll be assessing the woman's psychosocial state after she gives birth. How is she? Is she bonding? Is she just so tired? at this point, for her, she has just given birth and it was an exhausting process. And let's say it's been a 23-hour labor. For her to go like this and back, that does not mean that it's ineffective bonding or that you have to be worried about it. It means she's tired and fatigued. Come back later and assess the bonding. But at that point, we are not worried about that. We are going to do nursing diagnosis. We're going to be selecting risk for deficient fluid volume related to blood loss and antepartum period, risk of trauma. This is the point where we're really worried about hemorrhaging, amniotic fluid in blood, retained placenta, uterine inversion related to the delivery of the placenta. Okay, so when that placenta comes out, the doctor's going to be looking at it, and there's two sides of it, and the shiny Schultz side is the side that was to the fetus. And with that, he's also going to be looking at the umbilical cord. And in it should be 2 arteries and 1 vein. And you'll see it, he'll slice it after he's cut the baby's umbilical cord. He'll show you, and you can see as well, that there should be 2 arteries and 1 vein. The 2 arteries are going to carry the waste to the mother, away from the baby, and the vein carries oxygen-rich blood to the baby. So I know that seems backwards, but don't get that confused. And then Dirty Duncan is going to be that rough side, and that was the side that was on the mother, the maternal side. And with that, you're looking to make sure that none of that placenta got left behind, got left inside, that there's no fragments. If there are, you would be worried about hemorrhaging. And so first thing, as soon as she delivers, you are going to go and you're going to rub her fundus. And you need to have 2 hands, one on the symphysis pubis and one above top on that fundus portion. And the reason we do that is to make sure that you do not invert the uterus, that you don't cause it to flip over or anything like that. And so you'll massage that fundus and make sure that it is tight and firm and not boggy. Remember, if it's off to the side, that could mean that she has a full bladder and she needs to go ahead and empty her bladder. Major goals during the 3rd stage of labor: the new mother will maintain adequate fluid volume and she'll remain free of trauma. We're going to prevent fluid loss, we're going to maintain safety and prevent any kind of trauma. Now, this is the 4th stage of labor, and this is just the recovery stage, which is very important. We're assessing her vitals, we're assessing the mom for any kind of hemorrhaging, we're assessing her lochia, we are looking at pads, we are looking at her perineum, and we're making sure that she isn't bleeding from there. If she had a laceration, if she had a hematoma, she could be bleeding inside, so we have to look. We have to encourage her to counter pads, to look at the lochia, to know what it looks like. We're going to be monitoring for signs of infection, monitoring for suprapubic distension, for the woman's comfort level. Does she need some kind of pain medication now? Psychosocial state after the 4th stage of labor, and then that initial bonding behaviors between the whole family. Are they able to bond? Is she wanting to breastfeed? Was she able to breastfeed? Looking at those things. Okay, so also nursing diagnosis, we're worried and concerned about risk for impaired parent, infant attachment related to disappointment regarding the gender of the newborn, or an unwanted pregnancy. Sometimes if they've had congenital anomalies, cleft palate, this can be a little bit hard for the parents to see. And we want to make sure that bonding still takes place even if there is a congenital anomaly. And how do we talk through those things? How can we help the parent even work through guilt or anything that parent might be feeling? We're also worried about deficient fluid volume related to the possibility of hemorrhaging, formal site of placental attachment, risk of infection related to invasive procedures, vaginal exams during labor, impaired urinary elimination related to perineal trauma during the delivery. Sometimes it's very difficult for a woman to go to the bathroom after she's had labor, and it's due to all that inflammation. And so sometimes it might take several times of her getting up, or you might even have to do a straight cath initially But if you feel that her uterus is off to the side, she's not able to void, she doesn't have the urge, or maybe she has the urge but she just cannot go, you might go ahead and do a straight cath to empty your bladder and then try again later. Acute pain related to the episiotomy, birth trauma, or after pains. If there was a slowing of the labor and the baby wasn't able to come out and they had to use instrumentation, she might have cuts, she might have lacerations from that. And so we have to look at those sites. We have to make sure that she isn't bleeding from an episiotomy or a laceration, or that she has a hematoma. If she is having extreme amount of pain and you can't see any bleeding, she could be having a hematoma. So we're assessing that. We're looking at her perineum and making sure that all looks okay there. And then of course fatigue related to energy expended during labor. She just gave birth to a baby, and that is enough to make any woman very, very tired. Appropriate goals: parents will begin a positive bonding process with their newborn. The woman will maintain adequate fluid volume, still have no signs of infection. And remember, whenever we're looking at these pregnant women, after they have had labor, their white blood cell count will be elevated. It can be anywhere from 16,000 to 20, and that is normal. It's due to all the stress of labor. That she'll be able to void, that maintain adequate voiding patterns, that she will not become extremely fatigued, and have her pain adequately managed. So afterwards, we'll probably start her kind of on around-the-clock medications to make sure that that pain is under control, especially if she tore or had any kind of repairs in that episiotomy area. We're going to provide care immediately after delivery. We're going to promote that parent-newborn attachment, whether it's skin-to-skin contact, breastfeeding, whatever it is they choose. We want to make sure that bonding is taking place between the newborn and the parents. And then maintaining adequate fluid volume, preventing infection, promoting urinary elimination, minimizing pain, and reducing fatigue. All of those things, all right? So that is all for today. Thanks.